Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher. This is episode 95 today, and I'm going to start on a series of spotlighting modifiers. So I want the most used modifiers being spotlighted. I think it's important to focus on some of these important reimbursement tools. They're 2-digit codes that are added to the end of procedures, diagnostic services, sometimes E&Ms, that help. We're going to kind of break them down for you so that you can use them and make sure that you're optimizing your reimbursement, that you are appropriate in how you use them. I'm going to try and do at least one episode a month and see how you like the information. But I just think that it's really important that when we talk about these services and we talk about modifiers and really understanding the process, that when you choose to use them, that you're using them appropriately. Modifiers get doctors into trouble all the time, and we just want to really make sure that you're compliant, that if you're going to put a modifier on a CPT code, that it's appropriate, it's timely, and it follows the rules that not only CPT is set up, but also the payer understands what you're trying to do with that. So today's episode, I'm going to start with the 26 and 25 modifier. Actually, I probably did that backwards. So modifier 25 and 26. And then I think the next one I'm going to do would probably be 51 and 59. And then I'll get into 52 and 53. But I am going to try to do 2 episodes that I'm going to focus on modifiers. So we'll see how you like it, see if it helps you. And I'll try to give as many clinical scenarios as possible that speak to all specialties. What I'm hoping to do here as well is sometimes when you get denials, it has to do with what you're dealing with trying to work your AR. And to make sure that you're appending the correct modifier and that payers are listening to you, you want to look at this as a tool, because modifiers are really a valuable tool. They explain to payers the specific work that was done by the physician during treatment of a patient. And so they really help maybe represent the medical decision making when the code doesn't say it exactly how you want it to say. But the physician must demonstrate really exactly what's going to happen to be paid for the services they rendered. And so looking at the 25 modifier, there's some intent there that we have to look at first. So we're going to start with the 25, then we'll get into the 26. So to understand the modifier 25 better, if this is really going to speak to providers or physician practices that bill a lot of E&M services. So let's talk about what it is and then discuss how and when to use it. So as I mentioned, 25 modifier is a meaningful tool for physicians who bill evaluation and management services. So those are the E&M visit codes. And CPT defines the 25 modifier as, and I'm going to quote, a significant, separately identifiable E&M service by the same physician on the same day of the procedure or other service. So in other words, what they're trying to tell you is modifier 25 reports that the physician performed an exam which qualified as a significantly separate service from any other services rendered that day. But what qualifies that exam as significantly separate from the rest? So we want to look at some examples to get some clarification of that 25 use. And so example 1, let's think of a dermatologist. So they examine an established patient during a regularly scheduled skin check and perform a head-to-toe skin exam. During the patient's exam, a new suspicious lesion is discovered. The physician determines this should be biopsied and performs a punch biopsy. Okay, so in this scenario, the E&M would qualify as a separately identifiable service because they needed to update the patient's history from the past year. They needed to do a skin exam of moderate to high complexity, and the medical decision was made to go ahead and do a punch biopsy. So it wasn't determined before the patient came in that this is what they needed to have. So the correct and appropriate coding for this visit would be potentially a 99213, because doing any kind of biopsy without having any kind of qualifiers as high risk or any kind of other data reviewed, anything like that, was going to be low medical decision making. 25 modifier on that E&M service, and then the 11100, which is the biopsy code. Example 2 would be if a woman comes into her OBGYN office, and she comes in for an appointment, reports to her physician that she recently experienced an abnormal bleeding and pain. However, after the pelvic exam and regular pap smear are finished, these reported symptoms are not part of an obvious cause. So the doctor says, you know what, I think I need to do a pelvic ultrasound to investigate the problem further. Let's see what's going on and see what we're going to do there. So a 25 modifier is going to go on the E&M in this scenario because the ultrasound procedure is now used in an attempt to diagnose an abnormality that's not a procedure that is included. And so typically they're coming in for just a recent, or I should say a routine pap and pelvic, and the patient's saying, but I'm having these complaints and bleeding and pain is a problem. So now that's why you're going to do probably the U.S. Ultrasound transvaginal, which is the 76830. That's a standalone service. And the abnormality is not included in a routine OB-GYN office visit. So it would be 99213 again with the 25 modifier. Now I'm making assumptions with the level 3 because I would rather you caution on the side of routine visit. This is just one thing that came up. There wasn't additional qualifiers to make the medical decision making a level 4 or moderate. And so that's why I'm cautioning basically on the most routine office visit. If the patient's high risk, if there was more things going on from a medical decision-making HPI exam level, then obviously you would just adjust the E&M service appropriately. But just for argument's sake, that's why I threw in the level 3. And then another one would be a patient visits their cardiologist and presents with a complaint of chest pain during a physical exam. And they said that it happens really during physical exertion. So they call that dyspnea. The patient has a personal history of blood pressure, high blood pressure, controlled with medication, no other records reviewed, and no other risk factors. After the physician completed the E&M or the exam, he determined the patient requires a cardiovascular stress test, and they're going to go ahead and do a treadmill later that day. So to prevent the E&M from being bundled into the stress test, which a lot of times that does happen, the cardiology coder would use the modifier 25 on the E&M service to show it was a significant separate service that led to the decision to go ahead and do the 93015. So we have to make sure that, and that which is the treadmill or the stress test. And so we have to make sure when we do an office visit, especially for an established patient, we have to be just cautious with making sure that the payer understands that it wasn't something that was planned. And I'll explain in a minute how that works. Another example would be for GI. Patient presents to the ER for severe abdominal pain and rectal bleeding. The gastrophysician is called and performs a full initial hospital visit to admit the patient and suspects a GI bleed. It levels out at a 99222, so moderate level medical decision making, 25 modifier, and the diagnosis is pain and rectal bleeding. But after this, the doctor does suspect that GI bleed, remember. And so they take them in to the endoscopy lab for a colonoscopy. They actually find a polyp, and it was snared, so 45385, and diagnoses should reflect differently on each line item. Now, the CPT book says you don't have to have a different diagnosis. Okay, a recommendation, just if you're a coder and a biller, not just a coder, you need to be aware that when it comes to line item submissions, especially through electronic medical records, when you use a 25 modifier, you want the qualifier, so the ICD-10 code, to support your claim that this is a significant separate service. So for example, let's just say on that colonoscopy, the only thing you put on there was polyp. And then you went ahead and billed again for the admit or the initial hospital visit, 25 modifier, and also the 45385 for the snare scope. Well, you may have a payer that could look at that and kick it out saying, if you already knew it was a GI bleed, why are we paying you for an E&M service to tell us it's a GI bleed? So that's where you have to make sure that one leads to the other. So what you know at the time of the encounter is what the patient complained of, and then what you knew at the time of the diagnostic test is what your results were, or if you have a separate indication to go ahead and provide the test. And with all this, when you look at this from a billing perspective, You have to understand the necessity of justification of services. And I can't stress enough the importance of documentation, especially with the Modifier 25. So detailed physician documentation is really going to be your key here, because there are payers out there that want to reduce your E&M service when you use a Modifier 25. And so the provider must demonstrate their thought process in the required documentation. That's going to serve a critical role here, because without proper records, payers can continue to render determinations that you should only get paid for one line item. And that's incorrect. So with proper supporting documentation, even if a payer is incorrectly denying a service, now you as a billing staff can go and appeal those claims for reconsideration based on what the documentation shows the thought process of the physician. So when we're talking about that thought process of the physician, a couple things to keep in mind as you're really looking at that 25 modifier. Not only does the 25 modifier allow us to code physician services to the highest level of specificity possible, but it also ensures protection for that line item. It doesn't mean coding and reimbursement is dependent on that 25 modifier alone. Obviously, the physicians and the providers are responsible for sufficiently documenting the need for the E&M service separate from the procedure or diagnostic test subsequently performed. So you need to work as a team in order to create the clearest and accurate E&M claims and documentation to support both. So most of the 25 modifier denials, they come on the same day as a test or procedure for an established patient. Because the payers make an assumption that the patient was scheduled for the test or the procedure, and they think it was planned. So let me give you an example. This happens a lot in orthopedic. A patient comes in for chronic knee pain for the initial encounter, and the physician decides that they're going to go ahead and start a series of 3 Synvisc joint injections for the patient. They have them at different times. So the patient receives their first one today on the initial encounter, which is perfectly fine. 25 modifier with the patient office visit, saying that the office visit is what determined the need for the set of 3 injections, along with a 20610 for the large joint injection without ultrasound. But when the patient returns for the injection number 2 and number 3, there should not be an E&M coded with that injection, as the injection is now a planned procedure. So there's no medical necessity for the visit, and there's no medical decision making. This happens also in cardiology sometimes, where I'll see a patient that had an implant sometimes for EP or something, and they'll come back in and they'll try to just add on some kind of diagnosis. And you can't just put in a diagnosis saying that, well, it's different than what the procedure was for, so we can go ahead and code for it. It has to be something that was new or addressed to be able to separate it out. So just know if it's a planned procedure, planned test, and there is just some kind of maybe a history taken or a quick discussion with the patient, that's not separately billable. So it has to be where all elements of that E&M service was met that led to that separate service. That just shows that significantly different service. So now let's look at the 26 modifier. Now, the 26 modifier, this is a particularly unique coding tool in the billing and coding world, because this modifier explains to payers the specific work that was done by a physician during the treatment of a patient, and what was part of the facility, they're going to bill out something different. So this concept is really taken the step further when the 26 is needed, because it can only be used for certain kinds of procedures, which include what they call the professional component. So there's a lot of confusion among billers and coders with the 26 modifier, and let me see if I can kind of explore some of those confusions and some of that confusion, and help you give you some insight as far as the requirements on when it's coded and how to utilize it correctly. So you'll find there are certain procedures which are a combination of a professional component and a technical component. Most often you'll see this with diagnostic tests such as ultrasounds, CT scans, but there's also in the medicine section, I mentioned a heart cath before, and a lot of times this is really on radiology services as well. But let me break it down a little further. So the professional component is outlined as a physician service, which may include supervision, interpretation, and or a written report, without having performed the test itself, possibly. So you see how ambiguous that was? That was just so gray. So the 26 modifier Its correct use reports that the physician service was to interpret the results of a test when they may not have personally performed it. Now, that's just not always accurate, but that is basically the kind of the universal rule of it. But there are also codes in the medicine section that we're going to give you examples of that show you how to also use the 26 modifier and correctly define and report the physician's professional component. Some of it is procedural, not just interpretive. And the best way for me to really explain how you find out if you need a 26 modifier, your Medicare fee schedule has every CPT code listed that they allow. And in that fee schedule, if it's listed, if the specific code is listed one time without a modifier and there's nothing around it, then that's what they call the global service, and that's what you would code. If it's listed 3 times, so once with a modifier 26, once with a modifier TC, and then once without a modifier, that reflects that if you're providing the service in your office, place of service 11, where you own the equipment and you own the staff and personnel that's performing it, you code it without any modifier. But if it's performed in a facility setting, whether it be hospital, in or outpatient, ASC, just a freestanding lab, then you may need a 26 modifier for a professional claim. So here's an example of a couple of examples of the 26 modifier. So a sleep center performs a plethysmography for a patient. A physician not associated with the sleep center, they are on staff to interpret the findings of the test. So now that physician would append the modifier 26 to the 95811 code, and that's their interpretation. We call it, it follows the film for that plethysmography. And then let's say that there is a pregnant patient presents to the ER with a premature contractions. She's in the 20th week of her pregnancy. She's taken to the obstetrics floor at the hospital, and the hospital tech comes into her room, performs an ultrasound of a pregnant uterus, transabdominal approach for fetal and maternal evaluation, and only one fetus is apparent. So the OB-GYN physician on staff at the hospital received the imaging report post-test, and the patient's told to follow up with that physician. That specialist that's on staff, they are on staff to review it and interpret that hospital ultrasound, and so they would use that 26 modifier. The only exception to that, and sometimes this happens to other specialties, if a radiologist is the one on staff that reads the test and the OB-GYN physician is the one that just overreads it, then they would not be able to code it out as a specific interpretation. And then a treating physician takes a patient in for a cardiac cath, this is where in the medicine section, at the main hospital for unstable angina. So the physician would code the 93458 with a 26 modifier because it is a 2-component code. And the hospital would use the TC modifier as the technical component because they own the equipment, they own the staff, etc. Only a physician codes the professional service. Now the 26 modifier incorrect use, say the treating physician reviews a path report from a patient who had a breast biopsy, but the pathologist already interpreted the test. And that was the same situation with the OB-GYN if it was already done by a different physician at the hospital that's on staff to read either biopsy tests or to read radiological services. Then the treating physician can include their interpretation in their medical decision making, but they can't code separately for a interpretation or a professional service. You really need to have a clean claim on this because remember the facility that performed the test, they also have to file a claim for reimbursement. And that's why reporting the 26 modifier on the same code for the interpreting doctor is going to be really important. Otherwise, one or both providers may not get paid. I was recently, I guess within the last year, listening into a webinar for somebody who said they did cardiology and radiology coding. And one of the things they kept saying, and I almost lost it, was basically leave off the 26 modifier, you'll get paid better. And I was like, oh my gosh, no, don't do that. And everything they were explaining was that it was performed in the hospital setting by the physician that wasn't a hospital employee radiologist. I'm just like, no, they have to put the 26 on there. So it can become easy to get confused of the components of the procedure. So just remember this. If your provider doesn't own the technical equipment, then they can't bill for the technical component, which is included in the global service. And so you would put the 26 modifier on it if it is a 2 or 3 component code based on the fee schedule. And so just make sure that you are looking up those codes and you know when that scenario happens so that you're not over coding. Otherwise, that can be a huge issue because then the hospital won't get paid, you won't get paid, and everybody's kind of mad about it. So keeping you compliant is actually my job. So just want to make sure that you know who gets to code for what, who gets to add that on there. Otherwise, that can be a problem. Today's Codecast was also brought to you by Stranger Things, Netflix, the #1 original streaming live TV thriller of all time. Download the app today to any smart device and start watching. Also on Netflix, Black Mirror. Check out Season 5, Episode 1, Striking Vipers. Try the 30-day free trial today. Download the Netflix app on any smart device today. Okay, our coding question today is actually an X-ray question. So I guess that would be ortho and primary care and radiology. And it says, it's from one of my Oregon members. It says, how should I report an X-ray of the shoulder? Also, if the orthopedist performed X-rays on both shoulders, how would I report the encounter? So the reporting of the X-ray is actually pretty straightforward. You'll choose from one of the following codes. You either have the 73020 Radiological Examination Shoulder 1 view or 73030 Complete minimum of 2 views. And it's indented underneath because to save space in your CPT book. Also, you might need a modifier RT or LT to indicate laterality for left side or right side if the payer requires it. Medicare, if it's bilateral, Medicare wants the modifier 50 on one line item. So if it was 2 views, bilateral shoulders, then you would bill in 73030 with a 50 modifier appended. Today's coding question was brought to you by simplehealthradio.com. Join Dr. Emron on his podcast each week for important health questions and their answers. simplehealthradio.com. Okay, so my personal tidbit this week is, well, first I just want to shout out my daughter and tell her to stop bugging me while I'm trying to podcast. She's going to be mad at me for saying that, but she's driving me crazy today. It's like, I want to do this, I want to do that. I'm like, you know what? You're an adult. Leave me alone. So anybody have one of those? Yeah, join my world. So my personal tidbit this week. So I was really busy this past week doing audits and consulting and going from a couple of offices and driving around to different practices, doing a couple of assessments. And neither one of them were over, like, there wasn't a lunch meeting, there wasn't a dinner meeting, there wasn't anything that I could grab something quick to eat, and there wasn't a Starbucks around. As you know, I love my Starbucks. And there's something you need to know about me. I hate fast food. I hate it. I absolutely hate it. There's only one chain that's here. It's actually not a chain. It's like one place called Fantastic Cafe, and it's in Tustin. It's far from me, like 30 miles, and they have the best burgers ever, but it's far, so we never get there. But, you know, anything, McDonald's or burger, anything like that, yuck. It's just ooh for me. Well, when you're starving, at some point, you're like, okay, I'm going to pass out if I don't get something. And I had 5 more hours of meeting. So I stopped by a place out here in California called Carl's Jr. And I'm like, okay, I'm just going to get an iced tea and just something basic. So this is probably like a pet peeve, but I don't know if you guys are going to be surprised, but I was like, now I know why I don't stop by fast food. So I said, can I please have a cheeseburger? No lettuce, no tomato, no ketchup, just mustard only. And as I'm ordering, I'm noticing it's on the screen and they're charging me to not have tomato, lettuce, or ketchup. First of all, I hate ketchup. I mean, ketchup to me is evil. So I just don't like it. And I only like lettuce if it's shredded on a burger. So I'm so picky about that. I know people think I'm weird, but it's just like, I don't like, and fast food tomatoes just sound terrible. So I'm just like, I just want mustard on my burger. That's it. They charged me 35 cents for no tomato and no lettuce and 10 cents for no ketchup. And then just to add mustard, they added 45 cents. Mustard is nothing. It's like 2 cents. So I get up to the counter and I'm like, hey, you're charging me for not putting things on the burger. I go, and you're charging me for mustard? I can understand the extra cheese, but what is going on here? This is like 80 cents or something. And this is what she says to me. She goes, well, if they have to do more in the back than push a button on the computer, then it messes up our algorithms. And our chefs, okay, I almost laughed at that. Yes, chefs, okay, at a Carl's Jr. It takes more time for them. So if you want it your way, like Burger King, it costs more. And I'm like, but you're saving money. They just need to read the order. And she goes, well, yeah, they don't really read the order back there. They just get it back in a light. And I know I'm going to get cards and letters over this, people, but this is what people want minimum wage to be raised to $15 an hour because people can't look at an order and say, don't put certain things on it. So it's just, I'm still shaking my head, and you can tell I'm amused now, but I wasn't then. And it's not the money. It's not the money. I don't care about that. I care about the fact that they shouldn't be charging you for something you're saying don't put on it. So anyway, that's my personal thing this week. And for anybody who's ever, remember the Lethal Weapon series with Mel Gibson and Danny Glover? Remember Joe Pesci? What he said happens to you when you go through the drive-thru? Think about that. It happened to me today. Anyway, this is it for today's episode. Everyone, make it a great day. And until next time, thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.